Thank you, Dr. Haru. Good afternoon, everybody. So, I shall be briefly speaking about the treatment philosophy in the management of glaucoma. What is glaucoma? It is described as a family of ocular diseases characterized by progressive optic neuropathy and visual field loss. So what happens? There is a progressive retinal ganglion cell loss that results in gradual optic disc cupping, and this is associated with visual field deficits. And mind you, elevated intraocular pressure is no longer included in the definition. So what is the treatment philosophy basically? If we consider primary open angle glaucoma, the aim is to prevent nerve fiber loss, to prevent any further visual field deterioration, and most important, to retain the quality of life for the patient. If you see this curve here, as the age advances, or at the top, there is a normal physiological loss. So if you detect the disease at the point in the center, if you leave it untreated, it glows into the realm of blindness. So the aim of treatment is not to skew the curve upwards towards the normal side. You can't regain vision, but you have to treat the patient in order to see that this curve runs parallel to the normal physiological loss. Then visual field deterioration, whatever has happened, you have to maintain the visual field loss to the same extent, and in this case prognosis by recording also the 10-2 visual field. The quality of life is most important. It is hard to quantify, but for the patient it is the most important. The very diagnosis generates anxiety. The functional loss due to the disease, the inconvenience of treatment. For us it is very simple to prescribe this drop 3 times a day, 2 times a day, once at night. But how inconvenient it is if you are prescribed similarly for the rest of your life. The side effects of the treatment, and last but not the least in our situation, the cost of the treatment. So what we can do, can only modify and control IOP. Can we afford some sort of neuroprotection and vasoprotection to the patient is a bonus in the medical management. So whenever you think about medical management of glaucoma, you need to refer to this figure, how much range that you need to set, a target range for your patient in order to see that the patient doesn't progress within the normal range. So basically to come to a target range, you need to assess the amount of damage at the time of diagnosis, the life expectancy of the patient, and the IOP, the baseline IOP at which the damage has occurred. And based on these factors, whether the damage is early, you can have set a higher target pressure. If the damage is advanced, you have to treat the patient much more aggressively and bring down the target range to low. Similarly, life expectancy, if the life expectancy is long, you need to reduce the pressure further, and even the IOP damage has occurred at a lower lower intraocular pressure, you have to bring it down aggressively further down. So can you afford some sort of neuroprotection and vasoprotection? Studies are positive, but still yet to be established. So the treatment goal of glaucoma management is preservation of visual function adequate to individual needs with minimal or no side effects for the expected lifetime of the patient without any disruption of his or her normal activities at a sustainable cost. What all we have discussed in the previous slides boils down to this particular statement issued by the European Glaucoma Society guidelines. This should be the dictum, the guideline for the medical management of glaucoma. Now the next thing, after knowing the definition of management, what is the mechanism of action? Basically, the anti-glaucoma medications, they act at the inflow level by reducing the production of aqueous, and there are outflow facilitators. The outflow facility can be due to the UV scleral outflow as well as the trabecular outflow. So the outflow facilitators basically available for us in glaucoma armamentarium are the prostamides, the alpha-2 agonists, cholinergics, prostaglandins, and recent ROCK inhibitors, whereas the inflow reductors are alpha agonists, beta-1 blockers, carbonic anhydrase inhibitors. So the treatment goals, what do you aim to achieve? How do you assess a particular anti-glaucoma medication? You must assess by these 3 points. The ability to modify, and what is the ability to modify? It is the intraocular pressure, how much effective it is. The second thing is the safety profile, both ocular and systemic. And third thing, does that medication offer you some sort of a protection, a bonus, additional bonus by way of neuroprotection or a vasoperfusion? So the earliest form from the anti-glaucoma medication was pilocarpine. It used to act by opening up the angle and improving the trabecular outflow. Its efficacy was good, but the side effects of this was visual disturbances and brow ache, but it was a cheaper treatment. Then came the beta blockers. They revolutionized the treatment of glaucoma, and then followed by brimonidine. It has a dual action of mechanism. The side effect profile was hyperemia and drowsiness. Then came dorzolamide, brinzolamide, the carbonic anhydrase inhibitors. They have a different mechanism of action. They act at the production of aqueous level only, but since they act by a different mechanism of action, they can be combined with timolol. Then came the prostaglandins, the latanoprost, the travoprost, the bimatoprost, and of late the trafluprost. These four molecules, they act by increasing the UV scleral outflow and by giving some sort of a vasoperfusion, the endurance, and a better diurnal control all through the 24 hours. Then the recent kids on the block, the ripasudil and the netarsudil, they afford some sort of anti-inflammatory properties, and they act by opening up basically the trabecular meshwork, improving the outflow facility through the trabecular meshwork. The importance of combination treatment, as now lesser the number of drops, better for the patient. So if you see all the combination medications that are available in our armamentarium, all the medications up till now were combined with only timolol, but the introduction of brinzolamide brimonidine combination opened a Pandora's box, and it has led to such a situation that you can combine even 4 molecules in just 3 drops a day in 2 bottles. This is not a mathematical model. Every patient is different. How one patient reacts to this, every patient need not react to that. You have to select the best combination for your patient and manage your patient accordingly. So the clinical guidelines in medication always start with a first choice monotherapy. If the target pressure is reached, continue, IOP is maintained. Periodically verify the endpoints, that is, as I have said, the quality of life, the visual field, the optic disc, and the IOP. If the target pressure has not reached, the medicine is acting, but the target pressure is not reached, in such a situation, you need to add a drug. But if you have not the target pressure is not reached, the medicine is not acting, in such a situation, you need to switch the drug. So thank you very much for your patient hearing.
Do we have time for
if there's any quick questions from the audience? I think Dr. Mathur has actually covered very comprehensively the basic fundamentals of drug therapy without going into all the details, nitty-gritties, because they can't be discussed in 7-8 minutes. But I think there's a wonderful job done.